Bismillahirrahmanirrahim. I am Dr. Iqbal, Cardiologist. Today we are going to discuss an important topic, that is the heart failure. Heart failure is defined as it is a complex clinical syndrome with signs and symptoms that result from any structural or functional impairment of the ventricle filling or injection of the blood. Heart failure is basically caused by either structural abnormality of the heart, like dysfunctions, dilatations, regional wall motion abnormality, or structurally the heart may be normal and there is a function impairment, and because of this structure and the function impairment, there is the problem with the filling of the heart, that the heart can't fill itself, which is known as a diastolic heart failure, or there may be problem with the ejection of the blood, which is known as the systolic heart failure. It is one of the most commonest cause of the hospital admission and the death. Around the world, 54 million people are affected. In Pakistan, 2.8 million people are suffering from the heart failure. There are 4 stages of heart failure. Stage 1, these patients are at the risk of the heart failure. There is no structure or function abnormality, and these patients have not developed any symptoms. These patients include patients with the hypertension, atherosclerotic cardiovascular disease, diabetes mellitus, metabolic syndrome, obesity, exposure to the cardiotoxic agents, and the positive family of the cardiomyopathy. Stage B, these patients have also known as the pre-heart failure. These have not developed any signs and symptoms of the heart failure, but there may be the evidence of any one of the following. The patient may have the structural heart disease in the form of reduced EF, hypertrophy, and the valvular heart disease, or there is evidence of the increased filling pressure, which is because of the diastolic dysfunction, and which we can measure with the help of the invasive approach, in which we have the right heart catheterization, or non-invasive means with the help of the echocardiography. Then the third group is the patient having the risk factor of the heart failure, and there are abnormal biomarkers like elevated P-type natriuretic peptide or the electric levels of the cardiac troponin. In the absence of alternative diagnosis like the BNP and the cardiac troponins may be increased in the patients like acute coronary syndrome, sepsis, CKD, and the pulmonary embolism. Stage C, these are the patients who have developed the symptoms, either having current symptoms or the previous history of the heart failure, and these patients may be present in our emergency and the OPDs. Stage 4, these patients have advanced symptoms, they are refractory to medical therapy, and we go for the advanced intervention in these patients. Now the classification of the heart failure according to the ejection fraction. If the patient having EF is less than or equal to 40, these patients are known as the heart failure with reduced ejection fraction. If the previously patient having ejection fraction of less than 40 with interventions become more than 40, these patients are heart failure with improved ejection fraction. If the EF is 41 to 49%, these patients have mild reduced ejection fraction, and if the EF is more than 50, these patients is having heart failure with preserved ejection fraction. In patients with reduced ejection fraction, the symptoms is because of the reduced ejection fraction. These patients have systolic dysfunction. In patient with EF is more than 40, these patients develop symptoms because of the diastolic heart failure, and there is evidence of increased filling pressure, which we can measure with the help of the echocardiography, or the cardiac biomarkers may be increased in these patients. Causes of the heart failure, as we know that the most common cause of the heart failure is ischemic heart disease, in which we have the myocardial infarction. Then we have the cardiomyopathies like dilated cardiomyopathies, restrictive and the hypertrophic cardiomyopathy. Valvular heart disease also leads to the heart failure. Hypertrophy, hypertension, and diabetes not only cause the ischemic heart disease, but they also cause the microvascular ischemia and leading to the cardiomyopathy. Various type of the cardiotoxic agents leads to the heart failure, in which we have the chemotherapeutic agents like doxorubicin, alcohol, stimulants like cocaine, and various toxin exposures. Then we have the myocarditis. Most commonly the myocarditis in this patient develop heart failure. Tachycardia is important, that any tachycardia, persistent tachycardia, heart rate of more than 110 beats per minute leads to the cardiomyopathy, and there is a dilatation of the left ventricle and reduced ejection fraction. Stress-induced cardiomyopathy is sudden stress and LV become dysfunction. Most commonly occurs in the females and it is reversible. Pericardial cardiomyopathy is related with the pregnancy, and the chronic anemia may also lead to the heart failure. Symptoms of heart failure, as we know that the patient may be present with the most common symptom is the exertional shortness of breath, that is known as the dyspnea. With the progression of that is the patient develop orthopnea, in which the patient becomes dyspneic on night flight. Then we have the episodes of dyspnea during night during sleep, which is known as the paroxysmal nocturnal dyspnea. Patient may present with the cuff and the wheeze, or in the case of the right heart failure, the patient having the body swelling, especially the swelling of the feet, and the patient must present with the symptoms of abdominal pain and bloating. fatigue, dizziness, exercise intolerance, insomnia, and depressed mood, and simply because of the structural heart disease or because of the tachy or the bradyarrhythmia. The most common classification we use to classify the patients according to their symptoms is the New York Heart Association, in which we divided the patient into 4 groups, and then we go for their treatment studies. Class 1 is a patient having no limitation of the physical activity, in which the regular activity do not cause any fatigue, palpitation, or dyspnea. In case of class 2, the patient is having slight limitation of the physical activity. They have no symptoms at the rest, and the ordinary activity result into the symptoms. In case of class 3, the patient is having marked limitation of the physical activity. They have no symptoms at the rest, and the mild activity result in the symptoms. And the class 4, these have symptoms of the heart failure is present even at the rest, and the slightly exertions leads to the aggravation of the symptoms in these patients. And then the signs, as we know that the volume outload is the hallmark of the heart failure, and the signs of the volume outload are the weight gain, then we have the bivessel characters, pulmonary raised therapy, fetal edema, and ascites and hepatomegaly. In the cardiovascular examination, we may have the displaced apex speed, murmurs, systolic or diastolic, train and S3 gather, pulses, alternate tachycardia, and the hypertension. In the cases of left heart failure, there is accumulation of the blood in the lungs, which leads to the pulmonary congestion, and the patient becomes dyspnea. On the signs we have on the auscultation, we will find the bivessel characters. In case of the right heart failure, which is mainly caused by the left heart failure leads to the right heart failure, the patient develops abdominal swelling of the feet, fetal edema, abdominal swelling, ascites. Then we have the congestive hepatosplenomegaly, the patient present with the abdominal pain. Then we have the raised JLP. Investigation, we go for the routine investigation, in which we have the complete blood count, renal function test, LFT, serum applied, urine analysis, blood sugar, lipid profile, TFTs, and iron studies. These routine investigations are done not only for the risk factor of the heart failure, and also to look for the various predicating factors like anemia, infections, or the hyperthyroidism. And the most important is in case of heart failure, we have the electrocardiography, in which we look for any signs of the ischemia, previously myocardial infarction, or any tachy or bradyarrhythmias. In the late diagnosis, very important for the diagnosis and the prognosis of the patient with the heart failure is the B-type lactate peptide or anti-proBNP. This BNP and the anti-proBNP are the byproduct of the proBNP, which is secreted by the cardiomyocytes in response to the stretch. And in cases of the heart failure, there is a volume outload or the pressure outload, which causes the increased release of the proBNP, and it causes natural releases, increased excretion of sodium and water from the kidneys. And it is very important for the diagnosis of the patient with the suspected heart failure. If the BNP, in case of the chronic heart failure, if the BNP level is more than 35 picogram per ml, or anti-proBNP is more than 125 picogram per ml, it makes the diagnosis of the heart failure. Chest cardiography, we look for the signs of the heart failure, which we have the cardiomegaly, bed wing signs, upper lobe diversions, we have the Cardiologist lines, fluid effusion, and the chest X-ray is very important for look for the alternate diagnosis of the dyspnea, in which we have the pneumothorax. Echocardiography, we go for the structural heart disease and the ejection fractions. Additional tests we go if the echocardiography, in which we have the cardiac MR, cardiac CT, and the nuclear scans. Treatment is discussed at the stage A. These patients are only at the risk of the heart failure. They have the multiple risk factors, therefore their treatment lies in the lifestyle and the risk factor modification, in which we go for the exercise, healthy diet, avoiding smoker, adequate control of the blood and the sugar, and keeping an ideal BMI. If the patient is having type 2 diabetes mellitus and patient having atherosclerotic cardiovascular disease like myocardial infarction, CPA, aortic clog, and patient may have the peripheral artery disease, among all the anti-diabetic drugs, the drug which is very important in reducing the cardiovascular risk in this patient is the SGLT2 inhibitor, which I will discuss later on. Stage B, as we discussed the stage B, these patients not develop any symptoms, but they have the structural abnormality. Apart from the lifestyle and the risk factor modification, if the EF is less than 40, these patients have not developed any symptoms yet. We go for the ACE inhibitors, these are the beta blockers, they are classically indicated in these patients in order to reduce the symptomatic heart failure and the cardiovascular mortality and morbidity. Stage C, these are the patients having the symptomatic heart failure, Apart from the life cycle and the risk factor modification, we enroll this patient for the cardiac rehabilitation, in which the patient has been enrolled in various exercise programs, screening for the psychosocial disease like depressions, and we also improve the cardiac drug compliance of the patient during the cardiac rehabilitation. Sodium restriction is very important for the general well-being. We recommend that the sodium intake should be less than 5 to 6 gram in 24 hours. In the patient of the heart failure, the sodium intake should be less than 2 to 3 gram in 24 hours. Diabetes is a class 1 indicated in all patients of the symptomatic heart failure regardless of the ejection fraction, in order to relieve the symptoms of congestion, and we commonly use low diuretics to treatment. In the patient of stage C, patient with the reduced ejection fraction, these are the patients in which we go for the medical therapy. In the first line, we have the 4 class of drugs in which we have the ACE inhibitors, ARBs and D. Then we have the mineralocorticoid receptor antagonists, beta blockers, and the SGLT2 inhibitors. Among these drugs, in case of the beta blockers, not all beta blockers are same. The studies have shown that the beta blocker, which is reduce the cardiovascular mortality and mortality in patient with heart failure with reduced ejection fractions, only we have the carbidopa, metoprolol, and the bisoprolol. Then we have the renin-angiotensin system. In patient with the heart failure, there is a renal hypoperfusion, secretion of the renin from the kidneys, which convert the angiotensinogen into the angiotensin 1. Angiotensinogen is synthesized by the liver, which is converted into angiotensin 1. The angiotensin 1 is then converted into angiotensin 2 with the help of an enzyme which is known as the ACE inhibitors. The ACE inhibitors inhibit these enzymes, and they inhibit the synthesis of the angiotensin 2. Angiotensin 2 is responsible for the peripheral action of the angiotensin, in which it causes the increased release of the aldosterone, which leads to the increased sodium and the water absorption from the kidneys, and also it causes vasoconstriction, leading to the afterload of the patient. ACE inhibitors act on this angiotensin converting enzyme. It inhibits angiotensin 1 to angiotensin 2, but the problem with the ACE inhibitor is that it not only inhibits the formation of angiotensin 2, there is also the degradation of the various radioactive peptides like the bradykinin is also inhibited, leading to the increased level of the bradykinin, which therefore these 20% of the patient taking ACE inhibitors develop dry cough, and there is the increased risk of angioedema. Angiotensin receptors, because they act on the receptors, therefore the problem with the angiotensin 1 do not occur with the angiotensin receptor blockers. These patients do not have developed dry cough or angioedema. Then we have the third, which we discussed, that the angiotensin receptor blocker and with combination of the neprilysin inhibitor. It is combination of the ARBs and the neprilysin inhibitor. Neprilysin is the enzyme which is responsible for the degradation of the various radioactive peptides. In case when we go for the neprilysin inhibitor, there is an increased level of the radioactive peptides, which very important is the nitrate peptide. It leads to the increased diuresis and relief of the congestion symptoms. And the aldosterone receptor antagonists, in which we have the spironolactone and epinephrine, they act on the aldosterone receptors and inhibit the reabsorption of the sodium and water from the distal convoluted tubules and the protein ducts. Very important drug is the SGLT2 inhibitors. We know that the 90% of the reabsorption of the glucose occurs in the proximal convoluted tubule with the help of this co-transporter, that is the sodium glucose co-transporter, which causes the reabsorption of glucose and sodium from the ultrafiltrate into the blood. The SGLT2 inhibitors, in which we have the dapagliflozin and the empagliflozin, they inhibit this sodium glucose co-transporter, inhibiting the reabsorption of the glucose and the sodium. As a result, there is an increased excretion of the sodium and the glucose, and water also follows, leading to relief of the symptoms. But the problem with the SGLT2 inhibitors that it causes the increased excretion of the glucose. Therefore, it should not be given to the patient with the acute UTI. And also, it causes the increased excretion of the sodium and the glucose and the water. Therefore, we have to adjust the dose of the antidiuretics and also the antidiuretic. And it also causes weight loss. If the patient is refractory to the first line therapy, or we cannot use the first line therapy, then we go for the second line, which is very important, is the ivabradine, that is phosphorylated. It is a rate controlling drug. It acts at the funny sodium channels as the SL node, and it is given to the patient having EF less than 35, patient having NYHA class 2-3 seconds, and the heart rate is more than 70. Then we have the other class, hydrogen, nitrates, and digoxin may also be given to patient with the heart failure, but they are class 2 indicated. They are given according to the individual patients. Apart from the drugs which have the beneficial effect, there are certain drugs which may worsen the heart failure. In which very important is the non-dihydropyridine calcium channel blockers. That is the verapamil and the diltiazem. Because of their negative inotropic and the chronotropic effect, in the patient with symptomatic heart failure, if the EF is less than 50, we should avoid these drugs. Calcium channel blockers, in which we have the verapamil and diltiazem. Then we have the class C, 1C anti-insulin drugs, in which we have the flecainide and the tocophenol. Anti-diabetic drug thiazolidine, in which we have the postiglutazone and the rosiglutazone. Then we have the NSAIDs and the steroids should also be avoiding the patient with the heart failure because they got salt and the water retention to the body. In patient having the mild reduced ejection fraction or the patient having the preserved ejection fraction, the only drug which leads to the improvement in their quality of the life, reducing the cardiovascular mortality, reducing the hospital admission is only the SGLT2 inhibitors are indicated. They are in the class 1 indicated in patient with EF is more than 40. All other drugs which we use in the heart failure with reduced ejection fraction, in which we have the ARBs, early and the glucocorticoid receptor may also be used, but they are class 2 indicated. Stage D, we already discussed that this patient is having the advanced symptoms and refractory to the medical therapy. We have the option of the cardiac transplant, or we have the various left ventricular assisted devices, or just we go for the palliative care in these patients. So the take-home message in today's presentation is the adequate control of the cardiovascular risk factor is very important in order to prevent the symptomatic heart failure. In all patients with the cardiovascular risk factors, always look for the signs and symptoms of the heart failure. B-type natriuretic peptide or anti-proPNP is very important for the diagnosis and the prognosis of the patient with the heart failure. SGLT2 is only drugs which can be used in all patients with symptomatic heart failure regardless of ejection fraction and the passive status of the patient. Thank you.